Evaluating the efficacy of acceptance and commitment therapy in typically developing children by Cheyenne Ash, Jesse Hinman, Sarah Parkinson, Nina Rohale, and Cody Singer. Acceptance and commitment therapy is a treatment model that's often used as a type of cognitive behavioral therapy. It's based on the principles of behavior analysis and relational frame theory, and it examines the way people relate to the world through language and cognition. So rather than aiming to alter the content of cognitions or avoid negative experiences, ACT teaches people to mindfully accept all their thoughts, feelings, and experiences without becoming attached to them. Psychological flexibility is the overall goal of ACT, and to promote the achievement, maintenance, and growth of psychological flexibility, ACT describes 6 key processes to identify and practice. So those include diffusion, acceptance, attention to the present moment, perspective taking, values, and committed action. ACT has proven to be effective in a variety of clinical settings, and the U.S. Substance Abuse and Mental Health Services Administration declared ACT as an empirically supported treatment for depression and obsessive compulsive disorder, and for promoting general mental health and preventing rehospitalization. Recent studies have examined the effects of ACT on people struggling with chronic diseases and long-term conditions, such as cancer, chronic pain, and even HIV. The effects of ACT have also been examined with regards to anxiety disorders, anorexia nervosa, drug and alcohol abuse, gambling disorders, and internet pornography addiction. ACT maintains that experiential avoidance is a universal phenomenon, so it affects all people and is not just limited to a certain population. Given this understanding, literature has begun to expand the use of ACT to other populations, and more research is still needed to explore innovative ways to adapt ACT to these different groups of people. There have been some recent studies addressing topics such as challenging behaviors in individuals with disabilities, valued action for children with chronic debilitating pain, and children with autism and emotional challenges. Continuing this effort to broaden the types of populations with which ACT can be used, the current study will evaluate the efficacy of ACT procedures presented in the book ACT for Children with Autism and Emotional Challenges. ACT has already proven to be beneficial and effective with a number of clinical populations and settings, and this research aims to promote its expansion even further by continuing the exploration of its utility with younger populations. Results from this study will contribute to and set the stage for future research on adaptations of ACT, particularly more global school-wide adaptations that could be made to improve the psychological flexibility of students today. The participants in this study were 5 typically developing males between the ages of 11 and 18. Their median age was 13.67. The experiment was conducted in the participants' room of choice within their family's home. Materials used during the experiment included 10 programs from the ACT for Children with Autism and Emotional Challenges book, loose leaf paper for the participant, data sheets, and a recording device. 2 sessions, each consisting between 40 and 50 minutes, were conducted with each participant. Prior to the session, all participants gave assent and their parents or legal guardians provided written consent for their participation in the study, including video consent. A brief description of acceptance and commitment therapy was explained, though the purpose of the experiment was not discussed. Each participant began the experiment by completing a general demographics questionnaire. During the pretest, each individual completed the Child and Adolescent Mindfulness Measurement and the Acceptance and Action Questionnaire 2 assessment. The pretest questionnaire was used to determine the participants' experiential avoidance and psychological flexibility. The 10 programs were implemented over a 2-day period. During the first session, 5 programs were selected, which included Everyone Feels Bad, Sad Painful Experiences, Where Do You Feel Pain, Dealing with Sadness and Pain, and How Do You Fix Your Sad Painful Experiences. During the second session, 5 more programs were selected, and those were Your Party, The Blame Game, What Can You Do, Why Choose Willingness, and Be Willingly Out of Breath. As a post-test, the participants were given the same 2 questionnaires that they completed for the pre-test. This was in order to identify whether the acceptance and commitment therapy programs changed the participants' experiential avoidance and psychological flexibility. The participants' pre- and post-test scores for the 2 assessments are displayed in the table. For the child and adolescent mindfulness measurement assessment, the pre-test mean score was 9.6. The post-test mean score was 17.4. So the results did indicate that mindfulness increased. And for the second assessment, acceptance and action questionnaire, the pre-test mean score was 33.6 and the post-test mean score was 21.4. So the results indicated an improvement in psychological flexibility. We can see in the results of the first assessment that each participant's scores increased significantly after participating in the ACT programs. We can see that the scores significantly decreased in the second assessment, showing that the ACT intervention decreased psychological inflexibility for all participants. This study continued the effort to broaden the types of populations with which ACT can be used, and it showed that the programs from the ACT for Children with Autism and Emotional Challenges book were successful in increasing mindfulness and decreasing experiential avoidance. Results from this study contribute to and set the stage for future research on adaptations of ACT, particularly more global school-wide adaptations that could be made to improve the psychological flexibility of students today. Some of the limitations for this study were that we used a small sample size, the programs were conducted in the home environment, there was a limited duration of ACT procedures, and only one area of psychological flexibility was evaluated. Future research could use a larger sample size of participants. They could also focus on different age groups. We could also evaluate all specific areas of psychological flexibility, and additional research could be done with non-typically developing children.